A very good afternoon, our distinguished teachers, colleagues, ladies and gentlemen.
The Limi Children Hospital is a multi-specialty children's hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula.
That will try to make our people show any.
As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant.
We have the vision of becoming and remaining the leading regional world class.
For more information, log on to www.limichildren.org.
Based on godly principles. So Limi Hospital was founded over 41 years ago in Zaria before coming down to Abuja, and the Limi Children Hospital, where this presentation is, it's coming from, is an integral part of the mandate of the Limi Hospital healthcare system. So in 2017 was when the children's section was commissioned, and a lot of glowing commendations and accolades have been rolling in since our inception. Next slide, please. Okay, so we'll be discussing autism spectrum disorder, and with me to discuss this very interesting topic is Dr. Ayomide Oshagbami. Okay, so we'll be taking the presentation starting up with a case scenario, one of the cases we managed at the Limi Children Hospital. Next slide, please. Next slide. Okay, so it's our belief that by the end of this presentation, we'll be able to heighten our clinical suspicion of autism spectrum disorders, be able to recognize one when we find them in our practice, and also know the different management modalities of autism spectrum disorder. Next slide. Okay, we start with a case series. A 2-year-old male was brought in by parents with complaint of impaired communication, social interaction, and child was observed to be playing in a stereotypical repetitive way with lack of emotional reciprocity, and the birth history was unremarkable, and the gross motor development was essentially normal. There was no known familiar history of similar language or social impairment, and the MCHAT screening was 9 on a scale of 20. Next slide, please. Okay, so I want our participants at this point to drop in their answers. So what do you think is the likely diagnosis? What are the 4 possible differential diagnoses? And drop in the treatment or management modalities you think this child will benefit from. Okay, so let me check if, so just drop your questions, your comments on the Q&A. Okay, John Agugo has dropped his okay, he said autism spectrum disorder. Okay, good. Let's have the other okay, so just drop your comments on the Q&A section. Sorry, I'm in a meeting. Just drop it by the door. Okay, Asperger syndrome. Okay, this Asperger syndrome. Semi, is it the differential or the diagnosis proper? So just specify whether is the diagnosis your present, while we still have the questions, the answers to the questions coming in. Next slide, please. Okay. Okay, by way of introduction, autism spectrum disorder, it's actually a heterogeneous group of neurodevelopmental problems with polygenic inheritance. There have been a lot of postulations as per how the inheritance of ASD is, and there are a spectrum of or a range of impairment, if you like. The abnormalities can be grouped into 3. Can be grouped into impaired communication on one hand, impaired social skills, and a kind of let me have the next slide. Okay, so the over the past century, a number of researches have been done, and in order to try to unravel what has been the underlying cause or causes of this condition. And currently, interventions are not really suited. There's nothing like one approach that's, will be fitting for all the problems or all the conditions in this spectrum, especially in resource limited settings like ours. So alternative approaches are now being employed, including public health initiatives, family focused initiative, community. Part of what we are doing to sensitize us in the health sector for us to be able to recognize autism spectrum problems when they present to us. Next slide. Okay. So this the diagrams displayed, tries to explain some of the problems that we'll find in autistic children. Children with autism have some form of communication impairment, which could be verbal or non-verbal. Verbal are the problems that, like as we are doing this presentation now, you find that what I'm saying, for you to be able to get what I'm saying, means that I have verbal communication skills. So there's also the non-verbal, domain that has to do with, the like pointing to the door, telling the child to get something, telling the child to sit down or help you bring something. So if the child is unable to obey some of those instructions, it means that they don't have social awareness. It depends. For starters, if a child is unable to respond to some symbolic plays, exhibited by the parents, like peekaboo or the child smile, or if you find that a child is unable to respond to some psychosocial stimulations around, starting from the home, then when the child sees other children, when a child sees other children, there should be that interest in whatever the children are doing. If a child sees other children playing and fails to, get excited or get connected to the, the play that they are engaging in, then it might be a pointer that something is wrong. Then information processing. If you talk to a child and the child looks aloof, a child should be able to process some information. If you call a child's name, or if you ask a child, what is your name? And instead of the child saying, my name is this, the child responds, what is your name? It tells you that the child is unable to process that information that you're giving to him or her. So, these are the repetitive behaviors, playing in a particular way, in a stereotypical way, maybe playing with a toy, in such a way that the toys are arranged in, in line, and not, having some, kind of variation in the way he or she plays. It's also a pointer. Then the motor skills. A child that has a gross motor delay, like delayed neck control, delayed sitting, crawling, standing, walking, should be a pointer that something might be wrong. Because some developmental, delays might be the first sign that something is wrong. So if you don't pick it up from, when a child is unable to control the neck between 3 months of age, and you leave it to linger, by the time the child gets to between 2 and 3 years, you now start noticing that the speech, is delayed or is impaired. Then at that point, you might, have, so much work to do in trying to intervene and salvage this child's problem. Then the perseverative thinking. A child, having a kind of destructive mindset and all that, thinking of, always recalling something bad that happened in the past. When a child is only able to keep recalling something that went wrong. Maybe you see some children when they come to the hospital and injections are given, anytime they get back to the hospital, the kind of reactions or response they put up, it's out of proportion with whatever that most kids, even after pricking them and getting blood samples, they will gladly even come back and not remember what has happened. But here you find that the child is always able to recall something that went wrong, dwelling more on those bad experiences than being able to actually connect to some other, balancing this kind of thinking. If something goes wrong, no, nothing's spoiled. Think of some of the good things that were also done in the hospital, like the balloons, colorful balloons, and cheerful nurses and all other healthcare providers that were met in the hospital. So those are some of the things that might rouse your suspicion that something may have gone wrong. Okay, so let's look at the other inputs from our able listeners. Okay, number one, Olabisi gave the answer to the first question as autism spectrum disorder. Okay, correct. Number two, the differential diagnosis. Okay, the differential diagnosis, when we get to all the things in the spectrum of pervasive developmental disorders, we'll be able to know the other things on the spectrum. So autistic disorder is the main thing that fits into the spectrum, the major one in them when in the course of this person. But three, like we see, gave a multidisciplinary care, which is very, very correct. So treatment of autistic spectrum disorders is actually a multi-specialty or multidisciplinary problem that also needs input from different specialties. John Agugo gave autism spectrum as the diagnosis, the differentials, Asperger's syndrome, correct, Rett syndrome, correct, reactive attachment disorder. I'm not sure about that. So, but at least that was a very fair attempt. Amalachuko data, differential hearing impairment. Okay, so for the sake of this presentation, we'll just dwell on the things on the spectrum. There are other things that may also present with some level of, communication impairments, like Dr. Dita has, posited, but we want to just dwell on the things on the spectrum because of this presentation. All children with autism are not the same. I had seen a mother that before she came, to seek for help with our facility, had spent quite a lot of money, enrolled the child in a school where autistic children, are educated, as it were. So they are offering the same thing for all the children in the school. The same thing that is done for all of them. And what they do there is more of adaptive, helping them with the adaptive skills, being able to know when they want to wee, when they want to poo, and all that, which is just one aspect of the many things that they should bother themselves about. So that all children with autism are the same and needs the same support is a myth. It's not correct. You have to tailor whatever you're doing to different children depending on their needs. Because of this presentation, we'll see the different things, the different domains that we need to focus on, so that when we are offering help to these children, we'll be able to actually focus on all those areas of need and also encourage them in their areas of strength. The diagnosis needs to be made before treatment is commenced is also very, very wrong. There's an age. If you follow the DSM-5 classification or case definition of autism spectrum disorder, you find that there are ages that you diagnose each of those conditions on the spectrum. There are some you diagnose at 3. There are some you diagnose at 4. At 5. Now, if you wait until this point before making the diagnosis, before actually offering one form of treatment or the other, you find that you may not be able to, help them so much, because by 2 years of age, 80% of the brain has formed, and by 8 years, everything has formed. So if you're waiting for the child to get to those specific ages before you make the diagnosis and start treating, most times you may, not have a very good outcome. So by the time you find a child that is already having developmental delays, like poor neck control after 3 months, the child not being able to stand by 1 year, you need to, start doing something, because the earlier you intervene, the better the outcome. There's also another myth that trying to help autistic children is a waste of resources. Is not actually true. I can make both to tell us that we have been able to. So those that presented early will able to intervene. Those that needed some cognitive improving medications, we were able to offer them those, and we were able to at least record some very good results. Next slide, please. Okay, so I think this slide will help answer the questions. Number 2 questions in the case vignettes. Okay, so these are the 5 things on the spectrum of the pervasive developmental disorders according to DSM-5. So autistic disorder is the one that has those three impairments of communication, social, and some stereotypical or repetitive kind of behaving. So those 3 things are present in autistic spectrum or in autistic disorder. So the other thing we have on the spectrum are Asperger disorder. Here, the child's intelligence is intact. The child's communication skills is not impaired. It's only the social skill that is severely impaired. In fact, people with Asperger disorder are not able to keep relationships. They find it difficult to, engage in some very good social interactions, or they lack social skills, if you like. So I think some of us that find it difficult to, keep relationships going should check whether there is any, whether we're on the spectrum. Okay, that's on a lighter note. So child disintegrative disorder is the other thing on the spectrum. Child disintegrative disorder is found in children that had normal development up to a point. So a child develops normally till around 18 months, a year, 6 months, and they will now start, regressing all those milestones, speech milestone, social milestone, by, between a year, 6 months, and 2 years. A child that was able to speak, was able to, communicate both verbally and non-verbally before then. Now suddenly losing those skills should, rouse a suspicion of childhood disintegrative disorder. Childhood disintegrative disorder is commoner in males, unlike Rett syndrome that is commoner in females. In Rett syndrome, there's also, it's similar to what happens in childhood disintegrative disorder. Within the first 2 years, child is able to achieve those milestones, but now plateaus. We see a child that was able to, make some attempts at communicating, now getting to a point and not being able to, progress in those milestones. So commoner in females, also noticed around 2 years, and there is actually plateauing of the milestones that the child achieved before, unlike childhood disintegrative, where those milestones are actually lost. But both of them happen around 2 years, and the CDD is more in males, while Rett syndrome is commoner in females. Then the ones that don't fit into these aforementioned 4 conditions on the spectrum are classified as pervasive developmental disorder, not otherwise specified. Now, a child that has some form of impaired communication, but social skill is okay, doesn't play in a repetitive way, can fall into the 5th one. A child that has impairment in social skills, but communication is intact, then the repetitive play is not there, can also fall under pervasive developmental disorder. So can we have the other classification? Okay, so I wouldn't want to bother us with the ICD-11 classification because it can be a bit confusing. There are a lot of, with or without, mild, no impairment and all that. So let's just stick with DSM-5 classification. DSM-5 classification is the one I try to, dwell a bit on. It's more straightforward. We can easily, using the DSM-5 can be a bit confusing. So let's go on to the next slides. Okay, so Dr. Ayomide.
Yes, I'm here.
Okay, so you can take on the epidemiology so that before people will say there is a gender sensitive issue.
Good afternoon, everyone. Sorry for joining a bit late. So talking about the epidemiology, globally, the prevalence is about 7.6 to about 100. Now, however, over time, in recent epidemiological studies, it's been found that there's an increase in prevalence. However, this is not necessarily associated with the, it's not necessarily associated with new diagnosis, but because of the delay between the onset and when this diagnosis is made, and the more information that is now out there about autism spectrum disorder, more cases are being diagnosed, such as increasing the global prevalence. However, in boys to females, like boys to girls, it's about 4 to 1 in terms of ratio, and the prevalence is 26.6 per 1,000 for boys, while about 6.6 per 1,000 for girls. However, in Limit Children's Hospital, in our neuro clinic, from the data gathered and our own analysis, we realized that 1 in 5 children in neuro clinic actually are actually children that are diagnosed with ASD. So it's not as uncommon as people think or people might have assumed it to be. Also, there's also the underrepresentation in disadvantaged backgrounds because of bias and also because of data gathering. Most of the data gathered are usually from parents that possibly present to the hospital, and most of them are usually found in the upper class. So this might actually not be the true picture, but this is the data so far.
Okay, so let me throw more light a bit on the epidemiology. Over the past 1 year, we saw about 76 children with one neurodevelopmental problem or the other, and around 22 of such visits, was because of some level of social communication impairments and some stereotypical way of behaving, noticed, in these kids. And we're able to screen them with MCHAT, and we're able to, arrive at the diagnosis of autistic spectrum in them in the about 22 of the 76 children we saw. So that's how we came about the 1 in 5, children. So it's just for us to know how prevalent it is. It's something that most parents have read wide, most parents already to the hospital, already problem as in the children. The increase in incidence is not really to mean that it's rising. No, it's just that the awareness more now. A lot of social groups that parents belong to that discuss all these problems that come with the condition. And it will also be important for us to know that most hospital-based studies, most hospital-based statistics might just be in the, can just be described by the iceberg phenomenon. What you're seeing in the hospital is just a tip of what is happening out there. There are a lot of people that may not come to the hospital. There are a lot of people in the community that are not met. They make it a bit difficult for us to, have a comprehensive data on this condition. But let's just be around us, children that we dismiss as being stubborn or as being having taken after their parents and all that, might actually have this condition. Okay, so let's go to the next slide.
Okay, so going about the etiology, so basically we classify them into like the idiopathic ones, which is the most common, because so far there is no one single thing that has been identified as the primary cause of autism spectrum disorder. However, there's been a lot of hypotheses and a lot of suggestions as to conditions in which they've seen that people that have these conditions tend to also have ASD, but so far there is no one single cause that is identifiable. But there are risk factors, right? For the genetic factors, it's been seen that first-degree relatives, so if a first-degree relative has ASD, there's a high chance that someone from the family might have ASD as well. Also, monozygotic twins, there's a couple of research that's seen that the incidence is higher in monozygotic twins than in dizygotic twins. Also, some association with maternal age. So women more than 40 years when they had the children or had the child, and also if the father is greater than 50 years, this has also been seen to have quite a number of those children having ASD. Then gene mutations, especially on gene 2, 7, 16, and 17, as well as conditions such as Fragile X syndrome, tuberous sclerosis, have been associated with children that have ASD. So these are some of the factors genetically that is seen to predispose or that has seen to predispose children to have to having ASD. Then going to environmental factors, exposure to toxic agents, neurological factor, perinatal and postnatal factors such as perinatal infections, asphyxiated babies, quite a number of risks basically with the peripartum period have also been seen to be associated with ASD. But for now, there is no one single cause that can be identified as the primary thing that if you see this situation or condition in a child, the person will most likely have ASD. And also there are some comorbid neurological disorders, such as seizure disorder mainly actually. Most of the children that have ASD, especially for the Rett syndrome and the childhood disintegrative disorder, have been seen to also have associated seizure disorders, and EEG abnormalities have been confirmed in these children. Also, some problems with the cortical and the limbic system of the brain has also been identified, which actually explains some of the expressions they have in terms of their social capacitation and the verbal expression that is impaired as well in them. Then there was a post-mortem study that was done, and they've been seen that there's been a decrease in cerebral cells. However, it should be noted that depending on the age of the child that these post-mortem studies were carried out on, it's possible to actually see an overcompensation in the cerebral cells, so not necessarily decrease. But then again, these are just factors basically that have been associated with the condition. Moving on to diagnosis.
We will okay, let me try to highlight something about the cerebellum. There's a study that was carried out at different points in different children's development. So it was found out that around the time the cerebellar volume, in these children, where actually the volume was small, but subsequently, it was now found out that the volume, increased with age. Some of them might have normal OFCs at birth, but as they get old, the OFCs will now increase. Some of those areas of the brain that were small, at birth and in the first few months of life, towards the end of infancy and the early childhood, the kind of compensation of those more volumes. We now find that the sizes of those areas will now be larger than what was found earlier. So maybe as a 50 gene hypothesis, or maybe some other compensatory mechanisms, playing out. But those were some of the things that they found in the study. So for the diagnosis of autism, a lot of instruments have been, validated and, employed in the diagnosis of autism spectrum disorder. The commonest tool that is used both within and outside the country, especially in UK, is the MCHAT questionnaire. MCHAT is an acronym for Modified Checklist for Autism in Toddlers. So MCHAT is just an acronym. But MCHAT, although this is what we use routinely, MCHAT should actually be for screening, not for diagnosis. You want to know those at low risk of autism, moderate or high risk of autism. So by the time you're able to screen them and know those that are in the moderate and high risk domains, you will now apply other diagnostic tools that you will see in the course of this presentation. Now, the deficits in communication skills or interactions are the key things you're looking out for, or that these instruments try to, identify. And some of the three most important things you're looking out for, even if you don't have the tool to start administering on these children, you can actually, from your observation or from your history, once there is any social emotional reciprocity in the child, when the child wants to play, is in a particular stereotypical way, jumping up, clapping hands, or placing toys in a particular way, or if there is any deficit in the non-verbal communication, or that's for children that have more of impairment in their social interaction, or if there is any problem in developing, maintaining, understanding relationships. This you can find in the child not being interested in other children. When you take the child to his or her school or the church or any place where other children are, the child not being interested in other kids should ring a bell. So those are the things that you try to ask the parents, even if you are not able to administer the tools on them, just try and ask questions around these three key things. So once you're able to get responses that point to any impairment in any of these three areas, then know that that child might be autistic. Let's go to the next. Okay, so the I've talked that I wouldn't want to tell so much again on these things. I've already talked about them. The repetitiveness of motor activities, the child insisting, if the child wants to play or anybody wants to play with the child, it's like a ritualized kind of play. It must be in a particular pattern. The toys must align in a particular way. Once you try to, change the alignment of the toys, or you want to, change the pattern of play, the child gets angry or abandons the whole. Once you find any, you might be dealing with somebody on the spectrum. So then the fourth thing, let me just dwell a bit on the fourth the fourth point, say the child responds. Maybe the child will cry, or the child will just frown his or her face, or the child will walk away and all that. But if a child is angry and starts banging the head on the wall, or grabs any object around and smashes it, carries remotes and smashes on the wall because he or she is angry, that this, hyperactive, kind of response to such psychosocial or sensory stimulations is out of place. So that's another thing that is a pointer. Or you're trying to play with a child, bring a brilliant toy to the child, instead of the child getting all excited and trying to connect, the child stays aloof or withdrawn from all the things you're doing. That's another red flag that something is wrong. Next slide. Okay. So this will help us to. This meeting is being recorded. Okay, so this will help us know what we, by the time you see a child with, we've interacted with the parents, we've been able to identify what the problems are, in terms of those three domains that we just described earlier. Now, there are 3 levels. The child might require some support, or the child might require substantial support, or might require very substantial support. So these are the 3 levels. There are children that have some difficulties initiating social interaction. So then there are ones that have very, very, very limited interest. Then there are ones that both verbally, socially, and any kind of communication skill is severely impaired. So what you do, the ones that fall within the first level may not require so much, maybe medications and the rest. What, some behavioral therapy can help them, putting them in schools where they are, engaged in some symbolic plays with other children and all that can help them, improve in their social interactions. So these are things that are practicable that can be done, even at the level of the home, without necessarily putting them in any special kind of school for those that are in the first level. But for those in the second level now, you require to, engage them on a regular basis in some of these interactions that are limited. Engage them in things that will help to improve their interests. If they're only interested in a particular thing, by the time you bring in other things that are colorful, that will gradually draw their interest away from that narrowed ones they seem to be fixated on, that will help them, improve. So here now, there is no much that's, you may not need medications and all that for them here, but you might need more of all those speech therapy, behavioral therapy, and other form of cognitive therapies, but not medication specific. But those that fall within the third level now will require not just, they might have some gross motor deficit. They may not be able to move around easily, so you need to move them, you need to carry them around. So they will need some form of physical therapy, psychotherapy that will improve their cognition, and lots of help, in caregivers and other people who most times are the ones that, present to the hospital quite late. So by the time they present, you have very, serious work to do to try to salvage their, their functionality, the functionality of their higher cerebral functions as possible. So those are the 3 functional levels, an overview of what can be offered to these children. And believe you me, once you're able to offer them tailored help, the outcome will be better than what would have happened if nothing was done at all. Okay. Let's go to the next one. Okay, so these are the other things. You've made your diagnosis now. Beyond just making your diagnosis, there are other things you should be interested in. I've seen a child that, was autistic. The mother had, pumped in lots and lots of funds in, speech therapy, behavioral therapy, and, other things that helped improve the child's activities of daily living. but nothing at all was done about the cognition. So the child was just like a normal, he's able to change the diaper, he's able to tell you when he wanted to wee or poo, but if you say, what is your name, the child will be looking at you. No speech at all, no communication, nothing, no verbal communication, because what they were more interested in, sidelined the other aspects of the child's development, the intellectual, impairment that was part of his problem. So when you make a diagnosis of autism spectrum disorder, you should look out for, specifiers, things like autism with mild, moderate, severe intellectual impairment, autism development, autism with any other medical or genetic condition. You can have a child with Down syndrome, for instance, being autistic. So as you're making the diagnosis of autism or autistic disorder, also note the presence of any genetic abnormality, any trisomy, or any other inborn error, or any other thing that could also be a confounder of the child's problem. So if there's any neurodevelopmental, any gross motor developmental problem, any behavioral problem, any uninterestedness in life or anything that is happening, you should also accompany them in the diagnosis, so that what the primary problem the child has, you're also keeping an eye on those other comorbidities that will further impair the child's activities of daily living. So we should. Next slide, please. Can we have the next slide? Okay, so these are some of the things that while you're following them up, you've made your diagnosis, you've noted what the problems are, you've noted the levels of impairment. You should look out for some of these things, because if an autistic child has ADHD, for instance, I've seen a child that had autism and ADHD, and the parents were spending a lot of money, trying to school this child. But after a year, more than a year of not getting any improvement, the mother was almost frustrated until they came. I now realized that beyond just the autism spectrum the child equally had ADHD. So a child that is inattentive, a child that is hyperactive will not be able to sit down in the class to learn anything that the teacher is teaching. A child that is hyperactive won't be able to sit still in a speech, during a speech therapist section. So all the money spent will just be like pouring water on a on a rock that will just run off. So once we're able to place the child on a medication that calms the child down, within 1 to 3 months on the therapy, the child was able to sit still, started talking well, started doing very well in his class, and even came tops of his class. So this is just for you to know that all these associated characterizations are very, very important. If there is anything that falls within, I just gave a typical what you find in ADHD. So if there is autism and ADHD, sort out the ADHD. Once you sort out the ADHD, then you'll be able to handle the autistic disorder better. If the child has any problem with mood, having temper tantrums, hitting the head on the wall, when he's angry and all that, and you don't offer some behavioral therapy that will, focus on sorting out that hyperactive responses to anger and all that, or annoying, stimuli, that child, while you're trying to solve the child's problem, might grow into something you may not like. But if you're able to, manage this child's temper very well by offering, there are a number of things I tell parents to do. One of which would be, if a child is asking for your phone and you don't want to give the child your phone, instead of denying the child the phone and just ignoring the child, which will get the child angry, look for alternative things that will interest the child. You can actually get the child, a brilliant toy or some other thing that the child will, pick so much interest in. By the time you do that, you've been able to achieve two things: safeguard the, your phone from being spoiled, as well as also ensuring that your child doesn't end up, getting overtly angry and, exhibiting some of those pursued hyper reactions to the annoying stimulus. So let's go to the next. Okay. So the differential diagnosis include post-traumatic stress disorder, ADHD. I mentioned ADHD can be a diagnosis on its own. It can also be can be a comorbid condition you find in autistic children. I've seen a number of children that were autistic and having some hyperactivity as well. Obsessive compulsive disorder, mental retardation. A lot of things can, present as mental retardation. Trisomy can present as mental retardation. A child that is, okay, nowadays we don't use mental retardation. We actually say intellectual disability is a milder, non, stigmatizing a way of addressing, children that have some, level of impairment upstairs. So any child that has any condition that can lead to some intellectual disability, cerebral palsy, post-meningitic cognitive impairment, things like trisomies, some inborn errors of metabolism that impact negatively on the brain, can have some level of impairment in their social interaction or impairment in their communication. That doesn't mean that they are autistic. So childhood psychosis, I've talked about the post-meningitic sequelae, which can also, depending on the part of the brain that, was affected, if it's the speech area, the Broca's area, then that child's speech, the child that has achieved speech milestone now had serious bacterial infection that's involved the meninges, can have a regression of speech milestone. So, but the thing here is that regression of speech milestone, once you're able to offer them some sort of help, if you treat the infections very well, give concomitant adjuvant steroids, then these regressed speech or other milestones will be regained. That's the difference between it and the childhood disintegrative disorder or Rett syndrome that we described earlier. Next slide. Okay, so I think you'll be able to talk about the assessment tools.
Okay, so for the assessment tools, they are basically divided into two categories. We have those for screening, and then we have those that are diagnostic. However, these assessment tools are usually applied by highly trained personnel. So there's a level of skill that is required for a person to properly apply the tools. For the diagnostic tools, we have the child autism rating scale, which is used mostly in children, like the age group of that falls within children. Then we have the Autism Diagnostic Observational Schedule. This can be used both in children as well as in adults. Then we have the Autism Diagnostic Interview, which is revised. Also can be used in adult as well as in children. Then we have the toddlers, which was mentioned, the MCHAT, which is a modified checklist for autism in toddlers. Now, this is specifically tailored towards toddlers and is one of the commonest tools that is used globally.
And that thought, the first one is actually for screening. It's actually for screening. So once you use it and the child falls within the middle, okay, it has these are just questions that border around issues about communication impairment, social interactive impairments, then some abnormal finger movements and all. So they will all help you know if the child is at risk of being in the spectrum or not. And there are a total of 20 scores. Is on a scale of 20. So any score below 3, means that's from 0 to 2, means that there is low or minimal risk. Now, anything between 3 and 7 means that there is moderate risk. Anything between 8 and 20 means that there is high risk. So once you administer it, this is something that you can just, administer on. You give both parents independently to fill, to just tick. It used to be yes or no, but now they've changed it to pass and fail. So even beyond just screening them the first time, as in screening the child the first time the child comes to the clinic, you can also use it to follow up. The new one now allows you to use the MCHAT for follow-up so that you know what the score of the child was the first time the child came. Then the subsequent visits, know whether there has been an improvement or whether the child is regressing. That can also help you know if you're really doing well or not. Next slide.
So these are just a list of the tools I used for screening. You can see there are quite a number of them. So if either any of these tools are applied and it's used, it can be used to see if the child is at risk of autism or not. But it's quite important for us to use the diagnostic tools for us to make an accurate diagnosis of autism spectrum disorder. Now, just briefly talk about, I know
I think we've already talked about
the 4 other conditions under the spectrum. So this slide basically just kind of like emphasize on some of the things we already mentioned earlier. For the child with integrated disorder is commoner in boys, while the Rett is commoner in women, and both of them have an age range, usually around 2 years. That's when the regression starts to occur. And the Asperger's syndrome, and but basically the other forms of autism that doesn't fall within the other 4, as you mentioned, also called the atypical autism. Then we have peculiarities within the low resource setting, which is kind of part of the focus of our presentation today. And these peculiarities are highlighted so that we can also be aware and also use in our judgment as well as our assessment, and also help see reasons why possibly the data we have might possibly not be a very comprehensive data of what the number of children with ASD. First, we have the lack of experienced personnel across all disciplines. So like I highlighted a little earlier, most of the tools that are applied for diagnosis needs training, right? You need persons that are skilled. But finding childhood, and then the treatment also is multidisciplinary. So you need the child psychologist, you need the speech therapist, you need the neurologist, and some of these specialties are not found in ideal numbers or in adequate numbers in low resource settings. As a result of that, it makes it more difficult to be able to make an accurate assessment and also to be able to help children that have this condition. Also, we also have shortage of training opportunity, which is quite explanatory. We have constraint of resources, both human and financial, as well as infrastructural resources in low resource settings. Also, we have the language and cultural variations. So we're in a very dynamic country, right? We have different languages, we have different cultures. Now, most of the assessment tools, the tools that we use in making assessment, are not tailored to fit our indigenous language, for example. So if there's an impairment, like there's an impairment in a child, and we're trying to make a diagnosis, if the child's caregiver, for example, cannot communicate properly in English, then that itself is a barrier that makes it a bit more challenging for us to be able to make an accurate assessment. Also, there are cultural variations that put some children more at risk of possibly not being able to be seen as children that have an impairment, that need evaluation and that need help. Rather, there might be cultural approaches that are peculiar to those cultures that they might think might resolve the issue. However, intervention is not given on time, which subsequently affects the quality of life of such a child. There have social variations, which really is about your class. Like we have those from the very low income class, we have those from the middle income class, and then we have those from the upper class. Now, the level of access you have in terms of knowledge, in terms of resources, also influences when and how an intervention can be done for a child. So if a child is sick and child has fever, everybody feels, oh, child is not feeling well, they take the hospital if they can. But some of the conditions, or all the conditions really that highlight ASD, are not like things you would say it's an actual physical illness. So if it's not seen on time and seen as something that needs an intervention, this also impairs when and how the child is treated. Then also we have societal context. Okay. And yeah, so this is treatment basically. So these are some of the tools that Chief will be talking about for the treatment.
Okay, so the most, I wouldn't want to bother us so much about all the tools, but I would want to talk about the first one, Vinland Adaptive Behavioral Scale. Now, there are 5 things on that, the scale. It has 5 domains and 2 to 3 subdomains. Now, it tries to find out the maladaptive problems of the child, social problems of the child, communication problems of the child, motor skills, impairments of the child, and and a 5th one. When I remember it, I'll share it with us. So once this behavioral scale is administered on the child, you're able to know what exactly the child's needs are. If the child's problem is more of communication, you focus on the communication. You try to get the best of the child with the help of a speech therapist. If the problem of the child has to do with maladaptive behavior, being able to, okay, the 5th thing I just remembered now, if events of daily living. Now, if the problem of the child is that events or issues of daily living now, you dwell on it so that the child doesn't end up being dependent on the caregiver. The child will be able to go buy something, know how much his or her change will be, so that the parents will not need to accompany the child everywhere the child goes to. So those are some of the things that the Vinland Adaptive Behavioral Scale helps us to decipher. So once that is done, we're able to know what the child's problems are and now focus on it. The other things are also equally important, but for the sake of this presentation, I wouldn't want to bother us with that. So let's go to the next slide. So some of the medications we use, those that have impairments mainly in their cognition. There are CNS multivitamins, DHA plus that helps, hasten the myelination of the neurons in the brain. So the more the myelination is achieved, the more the child is able to, start doing some of the things that he or she is not able to do. Cognition improving supplements and atypical antipsychotics. These are things that we use. Even serotonin selective reuptake in receptor inhibitors are things that can help children with ADHD. Atomoxetine is one medication that we use a lot that has helped a number of children that have some level of hyperactivity, in association with their attention deficit.
So,
in conclusion, pervasive developmental disorders, from what we have heard in the course of this interaction, okay. From what we've heard in the course of this interaction, this pervasive developmental disorder, continues. The help you offer them is something that is a lifelong one. You keep offering those things that will help them in those areas of needs, irrespective of whether they are functioning, well intellectually or not. If you find that the child has problems with social interaction, keep, offering some behavioral help so that the impaired domain of the child's developing doesn't suffer. Because once you stop, the child might, regress back to where you started from. The goal of therapy is for them to live independently, be able to be, to be employable, enjoy their relationships and their mental health, not posing any major threat to their well-being. So once we're able to offer early and intensive and tailored therapy, we have very good communication and social outcome. Thank you. The prognosis is good if you offer them help early, but the prognosis can be bad if the diagnosis and the therapies you offer occur later. So I believe we'll be able to attend better to our teeming children with this autistic disorder, irrespective of where they fall within the spectrum. Okay, thank you. Somebody asked whether stem cell transplantation can be employed. Now, we've seen a mother that came with concerns about this stem cell transplantation. You need to know what the problem is. If the child's problem is something that is genetic, that has to do with the gene, then you'll be able to help them with gene therapy or stem cell transplantation. Not forgetting the fact that this stem cell transplantation has its own problems. It may work, it may equally fail, but there are some things that are practicable and result-oriented that we can offer, which form the nucleus of what we just presented. So let's just focus on what we can do that will provide the enabling help for these children, while we also leave these advanced technologies for those that maybe by the time we offer these baseline help and they don't make any significant progress, then that's therapy can be offered to them. Thank you. Thank you for your time. Thank you for being patient with us despite all the hitches we had along the way. Thank you and stay blessed. Okay, thank you.